So you may recognize Dr. Krol. I think we've at least discussed his work here in the consortium, if not had him sometime last year. He is, Dr. Krol is an assistant professor at the UT Austin Dell Medical School, and he's board certified in internal medicine and geriatrics. He's also the medical director at several nursing homes in the Austin area. He received his Bachelor of Science from UT Austin and his MD from UT Southwestern Medical School. After residency at Baylor and Dallas, he completed a geriatrics medicine fellowship at Duke University Medical Center, followed by an advanced geriatrics leadership training focused on enhancing the transition from hospitals to nursing facilities. Since the beginning of the pandemic, he's really been our go-to source for understanding COVID-19 dynamics in long-term care facilities. And so we're really excited to have him here today. And with that, I'll let him take it away.
Hey guys, so I found out about this recently, so I try to kind of put some slides in. I'm not sure exactly what is interesting for people. If this is something that doesn't pertain to you guys, I want this to be kind of a dynamic discussion where we can kind of discuss things. And if you guys have any questions, please feel free to interrupt me. Surprisingly, after all these months and a year of working on Zoom, I'm not very kind of good at it. So I'm going to try to see if I can figure out how to get my slides on board, but I apologize for any challenges I have. Let's see, share screen. Let's see if this works. Do you guys see my screen? Did it work? Okay, awesome. So I'm going to slide. So I want to spend a little bit of time talking about skilled nursing facilities. And I'm not going to spend as much time talking about the interventions I have or haven't worked. I want to leave that to the end for us to kind of discuss that. But I kind of want to just give a gestalt of some of the challenges and where we were starting off when the nursing homes were severely infected. And I kind of want to leave room for kind of discussions and kind of see where the people in the audience, the virtual audience, the questions go. And I'd be more than happy to kind of think through and kind of discuss some of the challenges we had beyond that. Just reliving the past a little bit, just remember where we were at. January was when WHO started reporting pneumonia-like cases. By January 31st, WHO issues global health emergency. And then by February of the 26th was the first outbreak. And I'll be honest, when we were having these meetings with the nursing homes prior to February 26th, everyone was having a lot of reasons why, well, you know, in China, they have higher smoking rates. It's not going to be that bad in our facilities. This is America. We were all kind of naive and not ready for it. And that was kind of our big wake up call, was when we saw the nursing home Seattle with 30% death rates. And we realized that what was going on there would easily happen anywhere, including all of our nursing homes. And so I think in order to kind of understand nursing homes, for me at least, to kind of conceptualize them, I kind of have to go the history of how they started and what nursing homes are. And so when we think about nursing homes, they really kind of date back to almshouse, which was kind of a British kind of idea of care. And so each community would have a house that would be for the indigent and the poor. Most of them were older adults, but not all of them. And so the county or the local government would pay for that house. And that's where they'd house people that couldn't afford to pay or that were unable to pay for themselves. And some of them would have to work for some of the payments. At the same time, there were some older age homes that were developing kind of later on the later side of things. And those were mostly religious or charity institutions. Some of the German or like some groups that came together would kind of put their money together to have a place for their older adults to live, Jewish, Christian organizations as well. So then 1930s, things changed, the Social Security Act. They realized that the almshouses were horrible and people were kind of revolting against the conditions in these houses. They said we could do better. And the reality in America, if you want to do better, you have to get the government out of your way and you have to give people money. And so their idea was, why don't we actually incentivize better care? And we can provide that using old age assistance program, and they would pay directly to these old age homes in order to take care of people. So instead of just taking care of their own, they could take care of the people in the community. And they'll say the private institutions will do better than the public institutions. We also found out that doesn't always work that way. So then people started protesting about, well, I don't know if they're doing that much better job. And there was a lot of issues and with some of the old age homes because they started kind of opening up all over the place because there was money to be had. So 1940s, the Hill-Burton Act came into power. And so the idea in the 1940s in all of medicine, definitely not nursing homes. We're just kind of, what happens in nursing homes is just kind of image of what's happening around America, was that we as with science can cure everything, right? Science, hospitals were big, this idea that we can have a cure, we can have vaccinations, we have all these ways to get rid of diseases. And so this whole push of creating a hospital-like environment inside nursing homes. So nursing homes were designed and built at that time to really kind of emulate hospitals. And in so doing, what happened was they took away the more kind of communal part of it, and they tried to really make it hospitals. They had long hallways. A nurse would be sitting at the end of that hallway. It was a hospital without a doctor. That obviously did not turn out really well. There was a huge problem that was kind of recognized in the 1980s, but through the 1960s, of these places having really poor care. And so from 1960s to 1980s, Medicaid was added in as a payment source. And so right now, if you are poor, like the alms houses in the past and the old age assistance program, Medicaid was that component of it. So in Texas, I looked it up, I think as of 2020, 68% of the patients that are living in long-term care at a nursing home are being paid for by Medicaid. It's a huge component of Medicaid costs, and it's a big reason why Medicaid has having a hard time kind of funding itself. Because if you could think about it, the number of older adults are growing. And so the way they can control the cost is by decreasing payments. They decrease the amount they pay. So a lot of these nursing homes in Texas, where we get paid one of the lowest rates out of any state in the nation, have dual or 3 or 4. Most of them is just 2 people per room, but sometimes they have up to 4 people per room in some of these rooms to decrease the cost because they're making so little off those patients. And the era of 1980s was, well, let's get away from nursing homes. They're naturally, nothing beneficial comes out of nursing homes, and move in towards assisted living facility. And I'd say now in the 2020s or the 2000s was the idea of living at home, and how do we create resources for people not to go to the nursing place in the first place. And so that's been kind of the transition of the nursing homes. Any questions, thoughts, nothing? Okay, perfect. Okay, well, I'll keep going then. So I will bring this as the thesis of the challenge of COVID-19, is that our system is designed on this kind of triad of conceptualization of care. We have really good knowledge about outpatient care. We have a lot of thoughts about how to create specialty clinics, outpatient clinics. We are hospital centric, right? This is from the 1940s. We're very strong hospitals. So we have a lot of hospital knowledge base, and we have a lot of expertise in hospitals. And everyone knows what a home is, and everyone kind of understands what the environment of home can and can't do. And we kind of assume everyone kind of bounces between these 3 kind of institutions. The problem with assisted living facilities, skilled nursing facilities, and long-term care facilities is that they're all of those 3 at once. So they're able to do components of all 3 of them. I can start IV fluids, I can give IV antibiotics, and yet there are none of them at the same time. I in no way have the ability to maintain infectious control protocols to a level you can in a hospital. They're not designed for that because they have to be more of a home. This is where people live. But I can't keep this place as much of a home and have this lax environment because it requires nursing level care. And so we have to kind of create a hospital environment. And so every single person kind of wants different things. So families would say, why can't you make this more like a home environment? And then when there's an infection, why isn't this a hospital? And then why can't we have the clinics come here? Why don't we have the outpatient clinic environment, the outpatient experts coming into the nursing home? And so in a way, it does a little bit of all three of them, but not really well any one of those three components. And I think that's the crux of, and that's the challenge of long-term care, especially when COVID came through. So I'm going to talk about, this is a little bit of this is from our own experience. A little bit of this is from a document that was posted by some of the colleagues that I kind of got to know while I was at Duke, and they're from Johns Hopkins. So I'm kind of combining some of the thought process behind those two programs. This all came out in the early components of COVID, but they're all, I feel, very relevant. So the first thing that happened, I think, in the nursing homes is there was complete lack of understanding. So the healthcare system initially, when you look at the CDC guidelines that came out initially, were all very hospital and clinic centric. So they would be like, well, these are the guidelines for hospitals and clinics. And so then the nursing homes are not neither hospital nor clinic. So they had to figure out how to adopt them. Do they adopt the home isolation protocols? Do they adopt the hospital isolation protocols? What do they do? And none of the nursing homes really knew what to do with any of that information. Initially, the long-term care facilities were also having regulatory agents. We're also kind of all over the place. Most of the regulatory agencies don't actually have anyone that is a nursing home physician. There's not a nursing home physician in any of the Health and Human Services right now. There's a nurse that runs it, but they don't, the nursing home side of things, they don't have someone that really understands the space as well. And a lot of the guidelines that they were going off from CDC were very challenging to implement in a nursing home setting. And the public expectations, kind of, as you all are aware, they wanted the hospital level care, but the home level of dependence. And how do you balance that? How do you kind of prevent people from coming in, but yet don't isolate patients when that is their home for years or so? There's lack of resources. So it was very funny because in the beginning, no one knew what N95 masks were. Now they all know. We all have to wear N95 masks, but I'll be honest, most of the staff have never been fit tested for an N95, so they're probably not really appropriate. We just had all these things that none of our nursing home residents and staff ever knew about. And so we had to implement all of these equipment, and we didn't have the resources to buy any of that equipment. And when we did, we didn't actually have the resource and education to actually teach them how to use it appropriately. And so it was very, the building we're sitting in was one of the first outbreaks that happened. We had over 50 people that get infected in this building alone. I think at the height of it, no, 60, with like a 23 to 30% death rate. And when we had it the first time, I mean, we went through all the training, but no one knew what to do. People were really scared. They were wearing like triple gloves and wearing 2 gowns, one in the front, one in the back, which actually made it harder for them to take it off appropriately without contaminating themselves. And so there's just a lot of limited resources, but also limiting understanding. Testing usually in the beginning when it first hit, not now, right now it's about 4 days for most nursing homes, but nursing homes didn't have access to rapid testing. And so when the outbreak happened here, it was a 10-day waiting for PCRs. So we would test for PCRs, we would isolate based off the PCR tests, and then we had to wait 10 more days. So by that time, the infection had spread dramatically. And so it was really hard because we were going off of CDC protocols that were based on rapid PCR testing, but we didn't actually have that ability. So that caused the state to expect us to kind of move people and isolate people when I knew that there was more, the negatives weren't truly negative because of the lack of timing for testing. And the staff, besides being poorly educated, the staff are really not paid all that much comparatively. And so a lot of the staff did not know what was going on, and they would not understand how to actually maintain protocols. So they would wear the mask, but then when they eat lunch, they would eat lunch together. And so a lot of education had to happen around that. There's lack of expertise. So this is, we don't have ID doctors that are coming in. I'm the only physician really that kind of comes into these facilities. And so there was a lack of how do we create guidelines that are appropriate? How do you create guidelines when you don't have enough N95 masks or PPEs? How do you create the best guidelines for where we are right now? And the problem was that there wasn't enough people. And then when we did have that information, there was too much information to where It left it to the nursing home providers to actually identify what they wanted to follow and what they didn't. And that was kind of really based on corporations or local control. So the physical building. So right now I'm housed in a building that's a historic building. It's over 100 years old. Has 2 HVAC systems because it was built in 2 different time periods. But to say that there's any actual filtration or air movement would be an understatement. Most of the rooms are double occupancy, so there's 2 people in each room. And so when outbreaks happen, how do you really, we would put a curtain between the 2 patients where one of them didn't have it yet. We were testing, but we knew that likelihood that both of them would get positive if one of them was positive during the testing process that took up to 10 days. We also, it was actually shorter here. It was like 4 days when it happened here. We also have a memory care unit where everyone has dementia and is ambulatory. So they're all walking around. They're all kind of talking to each other. It's really hard to isolate people that don't understand what's going on, that are drinking from each other's cups. And so when we did have an outbreak in the memory care unit, 100% patients got infected. We were unable to control it with the staffing that we had and the ability to kind of keep people isolated. So lack of community integration. So when initially we started working with Austin Public Health, they would get these tests, but they didn't actually know which patients were in a nursing home and which ones were not. So they would not know. So they would actually call us and be like, hey, is this a nursing home? What's an assisted living facility? And so because there was such challenge and there's no actual database of all the nursing homes or who to contact within the nursing homes, once the contact tracing was happening, a lot of these people that were positive, the facilities weren't being notified. And so they didn't know that. EMS, we're also not knowing who to contact, or we got a few calls in the beginning with EMS saying, we don't think this patient is appropriate for the hospital. What do we do with them? And the EMS could not figure out who the administrator was or how the hierarchy was set up to where they could have those communications with the people that were actually at the nursing homes or assisted living facilities. The hospital systems, difficulty communicating with nursing homes, assisted living facilities. The hospitals wanted to engage with us. I don't think there was a lack of want, but they were also kind of in the middle of the outbreak. And so they didn't know how to communicate with us, or how do they kind of send people back or kind of help triage things without sending them to the hospital. And so I think there was a limit. There was an eagerness, but there was a limited network built up ahead of time on how to best do that. And so that's not true with every place. So Johns Hopkins actually has a pretty established system. And so they were able to get doctors from the hospital systems, including ID doctors, to come out to these nursing homes and to kind of integrate better and provide more acute care really quickly to help reduce infections. And so they had these acute teams that were easy to develop because they had more integration between the nursing home community and the medical community, the hospital community. And the families kind of felt out of the loop during when everything was happening. Yeah, so I think that's kind of the general kind of consensus of kind of mine and kind of taking some information from literature about where things really went wrong. I think the challenging part is that you had to be kind of creative with the information, and a lot of people didn't feel comfortable. Like, how long can you rewear a mask? Well, we only have so many masks. What would be appropriate for that? And so a lot of the challenges early on was just kind of figuring out how to be creative with the limited resources and without much guidance that was really nursing home appropriate initially. Any questions or thoughts?
So I'd love to hear sort of a little more about your role, because I think that we originally reached out to you to come back and talk to us because I heard you on the radio talking about, or heard your name on the radio talking about the situation in Austin. I'd love to hear a little bit more about, sort of what is the role, what is your role? What do you see happening on the ground in Austin? How have things improved here? And where do you think we should be going kind of in the short and the longer term to improve the situation?
So that's kind of the basis, that's kind of my thesis about what went wrong. I think that a lot has improved since then. I think that unique on the statistics, and we have the data because we're monitoring how many nursing home and assisted living facility residents are getting positive. And within the Travis County, within the nursing homes I work, it's about 90% vaccination rates for the adults, not the staff, but the adults. I'd say staff is closer to 60, 70 maybe percent. And so because of that, I couldn't pull the exact Travis County because I had to like sell. I couldn't figure out how to get that graph to look all pretty. So I kind of gave up. But this is from CMS, and this is United States data. And the other one, the general US infection rates, I just kind of pulled that from New York Times. And so when you could see kind of like infection rates going up and the nursing home is just barely peaked. In fact, these are where we had 20, 30% passing away in each facility. I have not lost a single patient. And to date, out of all my facilities, I have one facility that has an outbreak of 5, they're all asymptomatic. And another facility of outbreak of 5. We've lost within Austin Geriatric Specialist, 2 to 3 patients. 2 of them were already on hospice and 1 of them was severely ill. So it's night and day, that change that has like occurred. And I would love if anyone of you all is willing to kind of dig through the data and kind of just pull Travis specific data. It would be really interesting to see, because I think some areas in Texas have like 40 or 50% vaccination rate for their residents. But we do have this kind of unique place where everything's lined up for us to have really poor infection control. Even though we're trying really hard, there's low staffing, the facility makeout. And so you would think that there would be larger outbreaks, and there were, and then vaccinations happened, and we haven't seen that rebound that everywhere else saw in the community. And if you look at nursing homes trend pretty well to where the community outbreaks happen. So when there's an outbreak in the community, there's a high risk for staff to get it. And so it usually kind of spreads into the nursing homes. We haven't seen much control, really, even though we're doing a lot more testing now than we did earlier. Once it spreads, it's kind of hard to control. And so the fact that there's this huge dip is quite impressive. And I think in itself tells the story of the benefit of vaccinations.
So sorry, what were you just saying about testing? So you're not doing regular testing of unvaccinated staff, or you are?
So we do, they're doing it twice weekly. They're doing the antigen testing. We're not doing PCR just because antigen is prolific and we have access to it. So we are doing antigen testing, but that's just for the staffing, not for the residents, unless there's an outbreak. There's still limited, PCR is still kind of challenging to get done quickly. And so if we do have an outbreak, we still mostly do antigen testing. We're trying to do some PCR, but just depends on how quickly we could get that information in.
Are you finding cases through the antigen testing? Has that been effective?
Yeah. So the latest outbreak that I have was found through, it was a symptomatic unvaccinated staff member that tested positive, that led to a broader testing of the residents. And we did find a memory care unit with 6 residents that were positive.
Oh.
I don't know how beneficial it is overall, the testing regime, because we're not testing everyone and just kind of, but it is probably helpful to kind of identify staff. A lot of the issue is that a lot of the people have family members that are coming in. A lot of people have caregivers that are hired caregivers that are coming in, and we've had hired caregivers, the ones that kind of spread. So it's not always going to be the staff, even it's sometimes the caregivers and families that are causing the initial infection. This last one happened in a memory care unit. Those patients are walking around everywhere, as I said before, and so the risk for further spread is just extremely high.
I see. So you're not testing visitors or the hired caregivers who aren't your employees, right?
No, we're not testing any visitors because they're not our patients. So if it comes back positive, they're not in a clinic. So we can't test visitors. We can't ask for vaccination status of any visitors. It's against the law.
Are long-term care facilities in other parts of the country with different restrictions, state restrictions? Are they requiring testing or vaccination for visitors? Is that just a Texas thing, or is that just not being done anywhere?
I'm not sure if it's being done anywhere. I'm not sure on that. I know that Abbott has a specific regulation against asking if someone's vaccinated.
Yeah.
But I have not heard of places where they are requiring vaccinations for family members.
Thanks.
And staff, there's a push for vaccination for staff from Biden. They said they're gonna connect some funds to it. But I think at this point, if that occurs in Texas, it would be, right now, our biggest issue is that we're providing poor care purely on the lack of staffing. We're severely lacking staff right now. To the extent to where some nursing homes have like 3 CNAs a night for the whole nursing home. You know, it's so extreme right now. And so I can't imagine what would happen if there's even 10% of the staff quits because of vaccine mandate, the effect that it would have on the rest of the facility. So I think that hasn't occurred yet, and it might, but I just don't know how that will work.
Yeah, thank you.
Holly, you have a question?
Yeah, Holly.